department physician, Susan Mason, and she's going to talk to us about trauma and pregnancy.
Yep, so I'm from Middlemore, and just as a little aside in terms of Middlemore, just being a bit of a unique population, our latest maternity report came through. So we still are in a situation where in the Counties Manukau area, half of pregnancies are unplanned, and we have 1.6% of people who register for their antenatal care in the postpartum phase. So now I just need the remote. So generally with trauma, I mean, road traffic trauma tends to be a large part of what we see. And so the out-of-control teenagers who tend to drive drunk and crash their car, there were a lot of them who were female, and back a few years ago, most of them were either pregnant or had just had a baby, who may or may not be in the back and may or may not be restrained, but it just complicated matters. But we have now had funded implantable contraception for a while, and that Judel has actually made a difference to how much trauma in pregnancy that we're seeing from that sort of mechanism. Okay, let me see if I can get the slides moving on. So some learning objectives just to get your brain thinking through. We're going to go over the anatomical and physiological differences in pregnancy, because if you're not always working with pregnant women, you tend to kind of forget these subtle differences. Talk about the mechanisms of trauma sustained in pregnancy, both with a Middlemore focus but also a more generic worldwide focus. How we need to just rethink our ABCs for the pregnant patient and trauma. Talk a little bit about imaging in pregnancy, because this tends to be something that often is contagious and concerns people, and I'll present a case that really got this all started and us really thinking about, well, what should we be doing? I'm going to talk briefly about Perimortem Csection, and then very briefly about more minor trauma, even though we'll realise that that's still very significant. Okay, so what you'll see here is that in most part of the world, pregnant women tend to be more cautious. They actually have less falls, they have less road traffic vehicle crashes. But there is a definite spike in domestic violence in pregnancy, and that continues to be an issue here. But we also do see more of those motor vehicle crashes in that young group who, through just generally not being cautious, are pregnant in the first place, continue to drink and drive, and have problems in that regard. So, sorry. We'll move on now to our respiratory system changes in pregnancy. What happens is you have an increasing oxygen consumption, and with that you need to maintain a faster respiratory rate. You develop a respiratory alkalosis, you use up some of your buffering capacity, and so you're more prone to develop acidosis and be unable to manage that. That respiratory alkalosis, you've got a drop in your arterial PCO2. You also get, in later pregnancy, the diaphragm's pushed upright, and that means your functional vital capacity is lessened. It also means that if you're trying to put a chest drain in, that chest drain needs to be placed a couple of rib spaces higher, because you may inadvertently go through the diaphragm and place it in intra-abdominally. You get some changes from the relaxin and other pregnancy hormones. That means there's more laryngeal edema. The epiglottis is more floppy, and you may need a straight blade to lift this out of the way, but we're tending to use video more often. And just the mammary hyperplasia can sometimes restrict access to the mouth when they're in the supine position, meaning you need a short handle to actually get that laryngoscope in. I keep wanting to show you that slide, sorry. There's an increase in plasma volume, so that you've got an increased volume to go around the placenta. There's an increase in red cell mass, but it's less than that increase in plasma volume. You get a dilutional anemia. The heart's having to work faster and harder to make up all of that. Then as you get past 20 weeks and you start to get compression of the inferior vena cava by the gravid uterus, you can get a syndrome called supine hypertension, and that's when they're lying flat, the uterus pushes on the inferior vena cava, you get reduced blood return to the heart and hypotension because it's not there to continue circulating. The flow to the uterus and the pelvis is increased, and this in the setting of trauma can mean that you bleed much more rapidly. Arterial blood pressure tends to sit a little bit lower, and the coagulation system is ramped up. So you're more prone to your DICs, you're more prone to problems later on with DVT-PE. Oh, okay. So in terms of the anatomical changes, pregnancy is essentially an intrapelvic condition until about 12 weeks. By 20 weeks, you've reached the umbilicus, and you can estimate gestation beyond there by sort of 1 centimetre beyond the umbilicus per week. Now, this varies a lot depending on how many previous pregnancies they've had, depending on the lie, depending on whether it's a single or multiple pregnancy, but that's a rough idea. And so essentially in terms of trauma, we've got to remember that once you're at that umbilicus, you're going to start getting problems with supine hypertension. And when you're just a tiny bit beyond that, you're potentially viable, and you're talking about 2 patients. You also get reduced gastrointestinal motility, more prone to aspiration. This is the one group where we really still want to consider using cricoid pressure if we're intubating them. That increasing abdominal girth with a pregnancy stretches the musculature of the abdomen, and that means that it's less sensitive and less able to become rigid and guard. So our clinical exam is limited, especially in the setting of abdominal trauma. The bladder is displaced and more prone to rupture with trauma. And we've got an increased glomerular filtration rate, higher urine output, and so that's one of the things that we'll use for monitoring ongoing shock, and it's not so reliable for monitoring ongoing shock unless we consider that it should be higher than it is. Okay, right. In terms of estimating gestation, we've talked about above the umbilicus for 20 weeks and then each finger breath above that. But the other thing is with ultrasound, the bipyramidal diameter. And this is a big, long, scary set of words, but really it's easy. You find the head and you measure from the front to the back of the head, and it gives you a rough idea as to where you're at. So if that's more than 6 centimetres, you're more than 24 weeks, and that means you've got a viable pregnancy. Sorry. Right, moving on. No, we've gone through there. I'm going the wrong way again. So physiological differences in pregnancy, our OBS are slightly different with a progressive tachycardia throughout pregnancy. The blood pressure tends to fall and then may raise a little at the end. Cardiac output's up. The white cell count is usually higher. Mid-teens is a really common white cell count in pregnancy and doesn't necessarily indicate infection or significant trauma. A hemoglobin drops with that dilutional anemia, and because there's faster respiratory rate, the bicarbonate drops as part of that respiratory alkalosis and compensation. So trauma core criteria for pregnancy is still the same as in the non-pregnant, but we're also going to consider if there's severe maternal bradycardia to put out a call, because we know they should be slightly faster than normal, and this is particularly in that later stage of pregnancy. And if the fetal heart range is outside that normal 110 to 160, which we don't always get information on pre-hospitally, then we should put out a call, and we need to involve both obstetrics and neonates. We still need to prioritise airway. Again, thinking about C-spine control. We need to predict that they are going to be a difficult airway for those reasons we outlined earlier, and that they may desaturate rapidly. And so this is the group you really want to have ongoing apneic nasal oxygenation, so O's up the nose during intubation to maintain this. With regard to aspiration risk, cricoid, tilting the bed head up, and remembering that you may need to modify your technique to make you to cope with the anatomical issues we've talked about already. Breathing, supplemental oxygen's more important for these patients than others because they are breathing faster. The chest wall and the second intercostal space can be thicker, so as Murray was saying before, fifth intercostal space can be useful. We're going to put our drains and our needles a little bit higher in the axilla so that we're not going through the diaphragm. They have an increasing circulating volume. A lot of this is going to the uterus, and the placental blood supply is particularly catecholamine sensitive. so is sensitive to shock. This is the first vascular bed to shut down, and it's a relatively hidden response. So they can be quite shocked without you having significant changes in their observation. And we need to consider an abnormal fetal heart rate as the earliest sign of shock and look at monitoring that. With fast scan is still reasonably sensitive and specific in pregnancy, and that's within the limitations of fast scan, which we were alluding to before. So fast scan is reliable for picking up 500 mils of free fluid in the abdomen. It's not particularly sensitive with less than that. So essentially it's a good way of picking up is there a big bleed or not. So it's relatively sensitive and specific, but it's very operator dependent, and that's because you've got a big amniotic fluid volume within the uterus, and you need an ultrasound operator who is able to identify what's intrauterine versus what's intra-abdominal. So it just takes a little bit more experience. If we're going old-fashioned DPL, it's supra umbilical, although I've not seen one of those done for a very long time. Okay. We want to remember the supine hypertension. Now we can either tilt the bed if we've got a fancy bed that will tilt on its side. We can tilt a spinal bed if they're on it. We can manually displace the uterus, or we can put them in the lateral position if we've already cleared their spine. So manual displacement is just physically pulling the uterus to the left to offload that IVC. We want to remember pervaginal blood loss is a source of blood loss overall, but also that with abruption you can get contained intrauterine bleeding without any showing PV initially. And so we want to monitor what the fundal size is doing and if that's increasing, because you can get significant hemorrhage between the uterine wall and the placenta that initially is hidden. If they have a pelvic injury, they can rapidly exsanguinate. Balanced solutions are best because of that limited buffering capacity. And this is the group you really need to use O-negative blood, because we need to prevent resensitization. And any rhesus-negative woman with trauma should have anti-D given, and it's titrated using the Kleihauer test. Vasopressors are going to further compromise placental flow and should be avoided if possible. We want to remember that the fetus being distressed may be our earliest sign of shock and institute early fetal monitoring so that we can intervene if needed. And the guidelines suggest that perimortem C-section is done within 4 minutes for best outcomes of arrest. Now that is in all arrest causes, but probably in trauma we need to think about doing that sooner, which we'll go into. So perimortem C-section, if they're dead, it's going to be a bloodless field, doing a midline incision, and then you can either do a standard uterine incision through a lower section or midline. This is looking at caesareans in trauma, and it wasn't necessarily arrested patients. It was done either for fetal distress or maternal distress, and amongst more than 114,000 trauma admissions, there were only 32 emergent C-section. So this is not a common thing. They defined viability as more than 26 weeks and had heart sounds on arrival. And they had one fetal survivor amongst 3 mothers who went on and died, and the injury severity scores there were huge. 42 is truly major trauma. So an ISS of more than 15 is considered major trauma. So these were very injured women. This is looking at all cause of arrest, perimortem C-section, 38 sections, 34 surviving infants. The 8 cases of trauma all died, but that was due to unsurvivable injuries, so fatal gunshot to head or significant injuries with traumatic arrests in the field, which through blunt trauma is almost invariably unsurvivable. They didn't do any subgroup analysis as to whether there was fetal survival. They make the useful comment, in no case was the deterioration of the maternal condition with delivery. When they're starting out dead, you don't make them worse than dead. Okay. and they did comment that in trauma that is unsurvivable and the mother cannot be resuscitated, obviously the sooner the procedure can be performed, the better. And I think part of this is that the first step in the mother heading towards that arrest process in trauma is going to be that the placental blood flow shuts down. And so a baby of a mum who's arrested has already had a significant period of hypoxia and shock and is in a worse state to cope with that 4 minutes that babies whose mum had suddenly collapsed cope with reasonably well. And you should continue CPR during this. Sorry, I'm hitting the wrong button. This was a review of maternal trauma mortality, and they looked at those who had C-sections. They found no survival in that, but none of those mothers survived either. And given that there is actually a good survival rate in Perimortem Csection for cardiac arrest of other reasons, you need to consider that bias. So moving on down our alphabet to D, and we can go through any questions later. Even if mum has severe head injuries and is supportable, there may be good indication to continue to support mum while you allow steroids for lung maturation, or indeed support mum for a number of weeks to allow better outcomes for baby. So they should still be treated more aggressively than we may treat that patient if they weren't pregnant. We need to remember that preeclampsia and eclampsia can be a cause of decreased GCS in these patients, and may well, especially in the situation of falls or road traffic crash, be the reason for the injury in the first place. So it may not be a head injury, it may actually be this underlying condition, and that we may need to be giving the magnesium, managing the blood pressure separately. And while we're on the subject of preeclampsia, these patients physiologically are different again. They actually have a really restricted intravascular volume and very high systemic vascular resistance. And the result is with that if they're given vasodilators, i.e. standard induction agents, they will crash. Exposure, same old ample history, full exposure. We need to consider our obstetric history as part of this. Review the abdominal bruising pattern, because an incorrectly worn seatbelt, it should be across the, below the uterus, across the hip still and between on the sternum. If it's been worn over the pregnant abdomen, you've got a much higher risk of uterine rupture, abruption. PV exam is really in the domain of obstetrics, but we do want to have an estimate of gestation early, and again marking that fundal height so we know if it's increasing. CTG should be done instigated as soon as is feasible for those potentially viable babies who are more than 24 weeks. Having said that, it's incredibly technically difficult to get all the probes on a uterus that's less than 28 weeks, and often our midwives are reluctant to actually try. So there is difficulties with interpretation. But essentially fetal compromise is indicated by significant fetal bradycardia or loss of normal variability or decelerations. And it can also look at contractions, which if there's more than 1 every 10 minutes or more than 4 in an hour is considered sensitive for abruption. So we're going to move on to imaging in pregnancy, and particularly talking about CT and X-ray, because this tends to be our standard imaging within trauma. And we do still want to stick with the as low as reasonable achievable dosing of X-rays principle. But at the same time, all the evidence points to a higher rate of fetal loss from missed injuries than from radiation. We are more radiosensitive when our cell turnover is higher, and that's particularly in those younger gestations, particularly younger than 15 weeks. But under 10 rads, there's been no observable effects from the radiation involved. And so a safe threshold of 5 rads has been suggested. And one of the difficulties whenever you look at radiation is all the different units, so 5 rads, 50 millisieverts. Contrast can be an issue because it can accumulate in the fetal thyroid, although we've not shown any adverse events there. Now, lifetime cancer risk is another thing, and it's very difficult to quantify because the baseline rate of cancer through the lifetime is actually quite high. It's about 40%. And so there's various studies that have looked at this but found disputed and conflicting results. In that very early, less than 8 weeks, you may be even more sensitive to radiation than other times, but some cohort studies haven't found any additional risk. Less than 5 weeks is only thought to be less than 2% above background lifetime risk within childhood. So childhood exposure, if you're taking a newborn, this is again with that 0.1G, which is the 10 rads threshold. Males, 2.5% chance lifetime risk of cancer attributable to that imaging of 10 rads. Females, 4.78%. So it's not huge, but it's impossible to really quantify better than that. But that is twice what we've decided is a safe threshold. Now, if we look at what we'd be delivering through our CT machine, and this isn't so much on pregnant women, this is all our patients coming through. So some of them are even larger and the average doses are higher than our standard pregnant cohort. You can actually buy a lot of imaging with well under 5 rads worth of CT. So we need to do a careful individualised risk assessment. We only want to do one study, we don't want to have to do more, we want to use contrast if we need it. If the suspicion is this woman may have a liver injury and that's why you're doing the CT, it is reasonable to consider scanning just that portion and shielding the rest. It depends on what your clinical assessment is. So clinical judgment can be used to tailor scans. And CT remains the best test for solid organ injury. It's actually the most sensitive test for abruption. It's very quick and we're all familiar with how to look at a CT. So just going through a case that, as I said, was one that got us thinking particularly about do we need to rethink what we do. This was a 20-year-old high-speed RTC, intoxicated, found outside the car. We didn't know if she was restrained or tried to run away, unwilling to give any history, and uncooperative. She was fast scan positive, but only a small volume of fluid, and no intrauterine pregnancy was seen on that very rapid fast scan. Decision was to take her through to imaging because she was reasonably stable at that point, but she had a positive beta HCG and radiology said nope. So she was observed. It was late at night when she'd come in 11 at night. And overnight she became more hypotensive and tachycardic and increased fluid, and finally radiology acquiesced that yes, maybe there is some trouble that we need to CT her on, and found to have a renal laceration and a transection, and then went on to a laparotomy and tie-off, and later on the ward requested referral for a TOP. So this was the case that got us thinking perhaps we should change things and we're a little bit more proactive about CT. 5 minutes, thank you. Other imaging, ultrasound's good for intraperitoneal fluid within those limitations we talked about. You can get an idea of fetal well-being. Not always available after hours, and you need a very skilled sonographer to pick up any indication of solid organ injury, which is easily missed. MRI is out of the department, takes forever, safe for baby, except for gadolinium, which is teratogenic. Other complications that I'm going to quickly mention: fetal-maternal hemorrhage gives a transfusion-like reaction, can make mum quite unwell. Uterine rupture, profound shock, fetal parts more prominent, lots of pain. Abruption, preterm labour, amniotic fluid embolus, 80% arrest rate with that, significantly unwell mums, almost uniform fetal loss. DIC is common, and direct fetal injury. Penetrating abdominal trauma tends to affect mum more than baby, with higher incidences of fetal loss and maternal and death. You need a low threshold, but they may not necessarily need C-section delivery. Pelvic fractures, standard treatment for this. They may still be able to go on and give birth vaginally if needed. but if there's significant disruption of the pelvic architecture or an unstable fracture, then they will need section. Direct fetal injury tends to be associated with that head engaged in pelvis when it happens, but it's really uncommon. So minor trauma in the second half of pregnancy. You probably all at some stage seen women who are very anxious, having had a simple slip and fall onto their bottom in the later half of pregnancy. And the difficulty is that they're actually right to be worried, because even with relatively minor pregnancy, there is an increased risk of abruption, preterm labour, and with the sharing and loss of connection of that placenta, you get low birth weight and you may have fetal loss. So talking about abruption, this is the most common cause of fetal loss post-trauma, 50 to 70% fetal deaths, 20% will go on to preterm labour. But looking after motor vehicle crashes, severe injury, it's there in 13%, non-severe 7.5%, but no injury detected, still 8.5% of them have an abruption with those risks of later or delayed pregnancy complications. So we need to refer them for a CTG to see if there's evidence of abruption. Minimum of 4 hours, we're looking for any contractions. And as I said earlier pregnancy, that 24 to 28 week, it's very difficult. So women can be discharged home if they have a normal CTG, no contractions, no vaginal bleeding or fluid loss, reassuring maternal status. The lab tests are normal, and we've given them anti-D if needed, titrated it with the Clyhar if needed. And we're sure that they're safe at home because of those known associations with pregnancy and domestic violence. But they need to let their midwife know, and they need to be regarded as a higher risk pregnancy from that time onwards. And there's a sort of summary slide that you can look through and read through if you want.